The state of public health has drastically changed in the past 5 years. We've seen shifts in funding, partisanship, conflicting federal and local priorities, public distrust, and reduced access, amongst other challenges. Hello, and welcome to the Intersection Podcast. To those of you that are new to the pod, The Intersection is a Robert Wood Johnson Foundation project to create a space for leaders in advocacy and healthcare to share how they're building anti-racist health systems. I'm your host, Anton Gunn, and for this episode, I'm here with Health Equity Program Manager of Linn County, Ann Carter. And I'm also joined by Health in Partnership Co-Director, Lili Farhang, and the CEO of the Louisiana Public Health Institute, Shelina Davis. Today, we will discuss strategies to safeguard public health and reimagine a more equitable and inclusive system that is responsive to all communities. Let's dive in. What is it like right now to work in public health? Whether you're building partnerships or working with grassroots groups who are focused on public health, what's it like to work in public health right now? I'm going to start with you, Ann.
I'm thinking back to the beginning of the year and sort of the relative chaos that may or may not exist for some people relative to then. And someday this will make a great case study in terms of how long it took organizations or community groups to come together and figure out we need to take action, even if there wasn't clarity exactly around that type of action. So that's been on my heart quite a bit as I've observed that locally as well as across the country. I have talked with many about just the extensive changes in the federal landscape that are literally impacting funding, that are literally creating uncertainty. We had this grant. Are we still going to have this grant tomorrow? So I think about that uncertainty and chaos that's really been surrounding us for a number of months. Now, having said that, there's still really good and really important work that's happening.
Very good. Shelina, what is it like for you right now?
It's grim in terms of what's happening at the federal level, but also exciting. I think, I come back to my roots. I'm from the South, born and raised. I am a Louisiana native. And in the South, we have been grappling with these types of things on a local scale since I've been in public health, my entire public health career. In our state environment, there's been dismantling of systems, closures of hospitals, and elimination or reduction in funding in public health. And we've always had to find a way to work even within this and then be creative and imaginative in terms of what partners we really lean on and partner with authentically to continue doing the work. For me right now, we're actually able to really flex our muscle more in this moment in time, not just for like our community here in the South, but also connecting with our colleagues across the country to say, like, here's some of the strategies and tools we've been using in the South to navigate during these times where the people in power have never wanted all people to be healthy and thriving and live lives that give them opportunity. Here are the ways that we've done it in environments that have not been conducive, and here are the ways that we're continuing to do the work.
Good. Lili, what about you from your perspective in your world? What's it like right now?
It's really hard. So as a executive director of a nonprofit organization, it is very, very challenging to know, understand, be committed to figure out what is our highest and best purpose in this political moment right now. Just what are we meant to do? Like, what are we called to do? We're not a governmental public health agency where we have a set of expectations and requirements. We have a degree of privilege in that we can make major pivots. We have flexible funding, thankfully, from our foundation partners that allow us to make those pivots. And so I think I'm experiencing some sort of deep existential kind of questioning around public health as one system vertical in governance. When the whole thing is being attacked, it's really hard to just think about okay, here's how we're going to continue to do what we've been doing. And of course, we'll be responsive. But there's just this part of me where I'm like, is this the time? Is this the moment where you're meant to set aside everything and become an organization committed to strategic nonviolence and train all of our members and all of our people in movement activism to go stand in front of the ICE facilities that are going to be built. You know what I'm saying? Like, I'm sort of in a moment of profound questioning around what is our organizational highest and best purpose. That's hard. It's hard right now out there for
Yeah.
folks.
I appreciate the transparency. And I think that's a great place to stick for a second. I want to hear from Ann and Shelina about this. Like, how can we address urgent needs in a time where there's so many real threats to our communities without rushing the process or losing sight of long-term goals or even just putting them on hold? What are you doing to help people to address urgent needs when the threat may be coming from something different that you didn't see 12 months ago or that you didn't see 15 months ago? I'll start with you, Ann.
When I think of urgent needs, so one example would be our clinic, which is responsible for immigrant and refugee healthcare in terms of physicals and such, and immunizations. We had a resettlement agency here in Cedar Rapids based on executive orders in February. They are now half the size that they were.
Hmm.
They're no longer serving the needs of immigrants and refugees, and particularly refugees, the way that they were. And so what I see is part of our structure in public health is a collaborative that includes other partners in the city to do our community health assessment and our community health improvement plans. I do see a lot of organizations coming together to kind of figure out how do we take care of these urgent needs. The things that I think are not directly or not as closely addressed is what are some of the disparities that may impact some communities more than others? What are we doing to demonstrate support and care for individuals of our LGBTQ plus community? The list can go on. But what can we do? We must continue to collaborate and find, in some cases, new ways to collaborate.
Shelina, how about you? Lili said the word highest and best use. So how do you make decisions on highest and best use when there's an urgent need that might be a disparate place from where your long-term strategy might be? What are you doing in the moment?
Yeah, in the moment, I think we have to hold two things. Lili, she mentions movement, and we've been thinking a lot about movement building, but building movements takes time. So that is one thing that we're holding. And then also trying to figure out what is our role in the now. LPHI kind of sees ourselves as like an ecosystem connector, especially around data, because we house a lot of data that comes directly from electronic health records. And then we also house a health information exchange that could be leveraged for a lot of information. And that is non-governmental data, in the world where data is disappearing. And we know that in our state administration, data is powerful, technology is powerful, and we want to leverage that to actually improve health. We know one of the 3 priority areas in Louisiana is addressing maternal opioid mortality in our state. We really use language, we're pro-family, pro-maternal health. How we can help support the state is not just leveraging the data to understand the current trends in this population, but we can also help convene partners quickly, as well as leverage other assets so that we can make meaningful change. So it's like we're holding 2 things, while also then we're funded right now through Robert Wood Johnson Foundation to really reimagine public health at this moment. So we're also at the same time convening partners, not just in public health, but grassroots, mutual aid folks, human need folks like social services organizations to really help us rethink what does a reimagined public health look like in Louisiana across the South. We're trying to address the needs of where people are dying. That's where we have to focus. Where are people dying? So we have to address that immediately. And then while also holding, like, how can we build something that's strategic and long lasting so that we don't see this in another, 20 years, this dismantling again.
And it kind of segues to sometimes we have allies who, whether it be grant funding, not necessarily from the federal government or state government, but it could be a private funder. How do we continue to help our funding allies to support investments in progress that isn't rushed upon the organization and communities responsible for the change? Sometimes the horizon for support might be 3 years. You can't rush the process, right? So how do you have that conversation to reframe with allies? How do we support long-term progress and investments in progress that is not rushed, especially when you need communities and organizations together to take the time to get to know each other. Lili, any perspective or thoughts you want to add on about that?
The way I think about funders is that they need to be organized too. They need to be agitated too. When I started working, I followed more. I kind of followed the rules of the game. I took their word as straight and bond. And then I have just sort of learned like, no, they don't actually have the answers. They don't actually know. Those institutions fall prey to the same power dynamics, the same challenges, the same internal struggles. And so, in some ways, I view funders as another constituency or audience set of partners that I want to organize into thinking in a more expansive way about sustainability and what this kind of work looks like. I think there has been shifts, like foundations give more general operating grants out. They give more flexible funding grants out. They give 2, 3, 4-year grants. Obviously, that's not the right time horizon. I mean, RWJF is a good example. Shelina, we're in that same cohort as you guys, and they're trying to like bring their grantees together to actually figure some stuff out in a way that doesn't feel, to me at least, dictated by them, but driven by what their grantee partners are seeking. So I think what I would say is that they require constant tending, and we have to view ourselves as resource organizers to get them to a more expansive understanding of what it takes to support change-making efforts. The last thing I'll just say about this funding piece that's really challenging is that government is the only entity that can bring a lot of these ideas to scale, right? Foundations, they'll give us the money for the project, our power building partnerships for health. And then they'll be like, okay, well, how are you going to scale this? Well, not with the $250,000 you gave us, but who can scale it is the CDC and HHS could figure out how to make this kind of partnership a requirement. So one thing that's hard is we're not going to get any of that right now. I think all we're going to have is pockets of success over the next couple of years. And we just need to still grow them and then hang on to them until a moment comes where we can feed them into a larger system that can push them out, hopefully through.
Shelina, I see you want to get in on this.
I was just going to add to Lili, because I know as we're thinking about this, when we were writing or when we had grants to philanthropic foundations in particular, there was always a portion that we had to write about our sustainability plan, especially in health systems work. Often our sustainability plan was tied, to Lili's point, to government funding mechanisms and sources, like for Medicaid or other different financing mechanisms. And we are learning we cannot rely on that anymore. Even the government can't rely on that anymore. I know that foundations have said, I know they can't support all of what was eliminated. They cannot replace that one for one. Who knows how long this is going to last? But there is an opportunity to think about where can they support innovation, support things like the process versus like an outcome. I think many funders are actually starting to do that, but I know they can only do that with a small group. What does it look like at a larger scale for those of us? Some of us are privileged to be in that space, but there's more who need help. So what does that look like on a larger scale with partners, I think is going to be the key.
Very good. And I know this is a unique one for you, getting federal funds and state funds and maybe even some local partners in your community. But can you just talk about what you all are doing to try to shape the landscape of investment in the work that you do?
I actually want to put a slightly different spin on that question, if you will.
Sure.
I'm a newbie in the public health space. It's been 3 years, but I am not new in my career. And so I am almost at the point where I'm no longer asking the question, well, and so why do we do it that way? So my perspective is more in part in my specific role, which was designed as a health equity role, and then how that weaves into some of the other stuff that's happening around the state. And so many of my community battles have to do with encouraging city or other municipalities not to capitulate to this, that, or the other thing, and essentially over comply with legislation that's come through. My own title, as a matter of fact, has been tweaked this year, and job description. And so while we still talk about equity, because isn't that at the center of the 10 essential public health services? And in our assessment and health promotion area, it's a critical piece of what we do. I personally, and this is where I'll just be transparent, and very much wrestling with how I reconcile the fact that, yes, we hold this as an important value, but yet we are being cautious about how we use the words. When I think about, again, not just public health, but sort of the public sector in general, and not, I'll use that word again, capitulating. I can give you lots of examples where that's the case, not just in public health.
And Ann, I want to stick with you for a minute because you started by saying you're fairly new to public health, but not new in terms of professional experience and background. So my question is, why are you doing this work? What drives you to do this work, and what brought you to the space working in public health now?
That is pretty easy for me to talk about. I'm in my hometown. I was born and raised in Cedar Rapids, Iowa. My father was regarded as the first Black doctor in this town. In fact, the public health building that was erected in 2019 is named after my parents. But I went away for school and I was gone for 30 years and moved back. Did I expect to come back to my hometown? Heck no. Did I expect to be divorced? Heck no. But here I am in 2020, around the time of George Floyd's murder. I was still processing the murder of Ahmaud Arbery. At the time, my son was coaching at a small school in Southern Indiana. And so you may be familiar with Southern Indiana, where there are still KKK meetings on a regular cadence. And he said to me, Mom, I run around here, and I'm imagining rural Southern Indiana. And so by the time George Floyd was murdered a few months later, I had already been in sort of this deep state of, what am I doing to make this a better place for the next generation and beyond? Got real involved in social justice work at that time and ended up having a reorg at the corporation where I was working, and decided I want to not just serve on boards of nonprofits, which is important, and I still do that, but I really want to be proximate to people who live in the community and may have experiences that I don't directly have, but I don't want that to keep us from knowing each other and working together and building relationships. So that's how I got into public health.
Very good. Thank you for sharing that. Lili, I want to know, why do you do what you do? Organizing in communities, building partnership with governmental entities to try to get to better health outcomes. There's a lot of things we all could be doing, and nobody's getting rich doing this work. So I want to know, what drives you to do this?
Yeah. I think my conscience, and it's not to say anything of people who choose to do different work, but I think there's just so much pain and horror in the world. And for whatever reason, the higher spirits decided that it was too much for me to not be able to engage in that and try to repair some of that. I think my dad was an activist in Iran and immigrated to the US in the 1950s for school. We were one of those dinner table families where everybody was fighting all the time. Who could be more radical? Who had more protest stories? And so I think when that's like in the water from such a young age, and of course we all seek our parents' loving approval, it just felt like staying in this lineage that was already a part of my family, and knowing that activism and organizing could have a really powerful impact. Public health was a pure accident. When I got out of college, I had this amazing opportunity to do this public policy fellowship in New York City, where they matched you with a government agency to kind of learn how the sausage is made in government. And you got this book of 70 different placements at an agency, and the public health department was the only one that was like, the disparities in infant mortality, the Black babies dying at twice the rate of white babies, this is in 1999, is immoral and unjust. And as a health department, we must do something about it. And I was like, preach, put me at the health department. And so I fell into it because it was a place that I saw all those values and all those ideas and all those theories and all that history. You know what I'm saying? It just felt like a home for those things that drove me. And I got there, and there were all these amazing people who worked at the health department who were figuring out during the Giuliani administration how you could still talk about condoms, And just like the strategy that they needed all the time. I was like, this is really an applied social science space to bring all these ideas that we care about and all these harms that we talk about to try to address them. But what keeps me going is sort of the deeper familial, moral drivers that are probably present for most people in public health. Kind of an amazing group of humans that choose to come and do this work.
Fantastic. Thank you for sharing. Now, Shelina, why public health?
Yeah, I mean, for me, it goes back to place. My family has deep roots in the rural Delta regions of Mississippi, which is like the poorest of the poor area in our country. My father picked cotton in Mississippi. He was a sharecropper. My great grandmother, I've never met her, but I heard stories about how she basically served almost as like a doula or birth worker, because other than her being their care, unless they went to like Jackson, really their only source of care was the veterinarian. So like the community, particularly my grandmother, served and helped a lot of families in this area of Mississippi birth their babies during that time. And we have family reunions like every other year. Now our family's spread about the country, but we hear those stories. So those stories of service and really making something out of nothing and still creating thriving communities, even in that time, was just like embedded in me. So, I always had a passion for health in particular. And of course, many of us think health when we're younger. We think like the clinical health sciences. Like my dad, they moved to New Orleans when he was younger and he went to Xavier and became a pharmacist. So I was like, oh, I'm gonna go to Xavier and be a pharmacist or a doctor. That's what you think, that clinical medicine would be the only way. But as I was going through Xavier, which is a HBCU and a Catholic institution, a Black psych class I took was really opened my eyes on a lot of different things. And my Black psych professor, when I told her, hey, I was having this conundrum, I didn't really want to do medicine because I really thought I wanted to do way more to like think about how we dismantle systems and create policies that advance health. She was like, you should look into social work and public health, which I didn't even really know much about because my family wasn't in that realm. I ended up doing my master's in social work and public health at Tulane, and really right as I was supposed to start when Katrina hit, being displaced and being a visiting student, but did a lot of work really helping people come back home to New Orleans, like being on the crisis line. And most of the crisis was just people wanting to talk because they just lost everything. All of us lost everything during that time. Fast forward now, my work has really been grounded in not just like helping create health infrastructure in particular for people who didn't historically have insurance, who were going to the ER at Charity Hospital where my mom was born, but really helping people create these healthcare entities that treated people as human beings with dignity and respect, and that had providers that actually looked like them, because that's also helpful as well. And so what brought me to this work, I would say, is maybe it's just in me to be of service, but also my desire to really ensure that all systems in our environment works for all of us, especially people who have historically been denied access.
Wow. So powerful. I'm just grateful for the opportunity. Ann, Lili, and Shelina, thank you for joining me in rethinking a public health system that serves all communities. To our followers, I want to thank you for coming back for another great discussion. And to our new listeners, we're happy that you've met us at The Intersection. Visit us at meetattheintersection.org to sign up for our mailing list and to access resources and more conversations. We also invite you to join our LinkedIn community of leaders doing this anti-racist work. Thank you. The views expressed here do not necessarily reflect the views of the Robert Wood Johnson Foundation. The foundation does not support lobbying efforts, including any activities or communications referenced during this podcast.